Hello and welcome to this month's IMV Imaging Journal Club. My name's Amy, I'm one of the vets here at IMV Imaging. If you haven't been to Journal Club before, it is a free of charge monthly review of an interesting piece of research and you get a certificate at the end of watching. If you have any questions at all, any queries or any requests for future topics to be covered, then please do email us on clinical@imv-imaging.com. We love to hear from you, so please don't hesitate. Today, I'm going to discuss a couple of papers. So this is the main paper I'm going to look at, plus I'm going to look at a little bit of background work done by one of the authors. So this paper looks to kind of validate the sensitivity and specificity of using thoracic ultrasound for the diagnosis of active pneumonia in pre-weaned calves. This is a paper from 2019, so not super relevant, but one of the more pivotal papers in this really interesting area. So the background paper that I'm going to look at describes the technique which is used in the paper that we're going to discuss. And one of the authors, Buczinski, was involved in both papers, which is why I think it's important to examine this particular technique. So in this background paper from 2016, a bit of information to remind you of the pathology and why it's relevant for ultrasonography. In pneumonia, cellular infiltrates and debris effectively displace air from the lung tissue, starting ventrally due to gravity and then progressing in a dorsal direction. And this actually leads to an alteration in the ultrasonographic character of the lung from that of a strong reflector with reverberation artifact and A lines starting at the pleural interface to something that appears to be more of a homogeneous hypoechoic structure, which appears to be like the liver, which allows you to make a diagnosis of pneumonia regardless of the actual clinical state of the animal. And in a previous study from 2015, the depth of lung consolidation was one of the abnormalities actually most closely associated with an adverse clinical outcome, i.e. death, in a case-controlled study, and actually, above all, was the easiest parameter to measure with excellent inter-observer agreement. So thoracic ultrasonography is looking good as far as being a test is concerned. So I have a video on the next slide, courtesy of Phil Scott, which shows both normal lung and abnormal lung. So the purpose of this video is to remind you that consolidated lung is not necessarily associated with active lung infection, however, and it can also be found in cases of lung infarction, atelectasis, fibrosis, or scarring. So here is at the beginning, we have normal ultrasound picture coming in with the glide sign at the top, which is the pleural interface, combined with some A lines extending from the pleural interface across aerated lung, which is normal reverberation artifact for air-filled lung. Some consolidated lung, which you can see the lung consolidated there, moving backwards and forwards across the pleural space with a consolidation there, hypoechoic pattern with hypoechoic areas of bronchiole. So that is consolidated, diseased lung, which will have been caused by pneumonia. So the question is whether that is active pneumonia or whether that is chronic. So that's just an interesting video there showing the difference between normal aerated lung and fibrosed lung. So the technique that was used in both of these papers is to extend the examination from the caudal thorax to the cranial thorax by moving the probe along the grain of hair in a dorsal to ventral direction within each intercostal space. And I've included a breakdown of what we're looking for in the right and left lung, because the study that we're examining today has a key feature of the right cranial lung lobe included. So for both lungs, our caudal lung lobe is intercostal spaces 6 to 10, where you would expect to find focal pulmonary abscesses, which are markers of more chronic pneumonia and damage. In the right lung, we've got the middle lung lobe and the caudal part of the cranial lobe, where you would expect to find bronchopneumonia. And importantly, highlighted in bold, we've got the cranial aspect of the cranial lung lobe, which is at intercostal space 1 to 2. And this is where you will find bronchopneumonia as well. Significantly, it's most commonly affected lung lobe in dairy calves, and this comes from an unpublished observation by Ollivett in 2012. So it's quite an important lung lobe, which is included in the paper today. So to give you an idea of what the appearance of ultrasound then correlates to in terms of a post-mortem lung, on the left-hand side, we've got a post-mortem example from the ultrasound picture just to the right of it, taken from the right fifth intercostal space, which will be the right middle lung lobe. So the lungs are grossly normal. We've got a pleural surface where the glide sign would be seen. We've got reverberation artifact. We do have a couple of comet tail artifacts denoted by the bracket and the asterisk, which is a sign of pleural roughening, which can occur pre-pneumonia with inflammation. So, for instance, a viral infection. But what you can see grossly is that the lung is actually quite normal. But on the right-hand side, we have a grossly abnormal lung taken from the right cranial lung lobe, from the fourth intercostal space on the right. And this is affected by hypoechoic lobar consolidation. And you can see from the ultrasound image, it's very much like the video I just showed you. We've got hypoechoic consolidation, which appears liver-like with some hyperechoic speckles through it. So not at all like normal aerated lung. And it's quite interesting to see how that looks in the post-mortem example. So what is absolutely essential is to separate active pneumonia from non-active pneumonia that you get, for instance, with upper airway respiratory disease, scarring or fibrosis of the lung, because this has important implications for whether we're treating the animal and whether we're applying antibiotics. So there's a lot of pressure on antibiotic resistance today. So farmers rely on clinical signs plus the calf respiratory scoring system, which is used a lot in North America. And if you combine those two procedures, you're looking at a combined sensitivity of around 62% and a specificity of 74%. Vets are accessing clinical signs plus auscultation of abnormal lung sounds. So we're having a combined sensitivity if we use those two tests of 73% and a much lower specificity of 54, which is not great. And then we have haptoglobin blood test, which is a measure of an acute phase protein. So if we put the cutoff at 15 milligrams per deciliter, our sensitivity is 64% and specificity is 70%. So these tests can all be useful for diagnosing active pneumonia in calves, but none of these tests is a gold standard for that purpose. So our gold standard really is necropsy, probably including bacteriology on exudates. So an alternative approach to assess the accuracy of thoracic ultrasound for diagnosing active pneumonia rather than just consolidation is to use a Bayesian latent class model, or LCM. So in these models, we choose a Bayesian framework because none of the methods are considered gold standard. And the disease status, which is active pneumonia for our paper here, is designated as latent, so existing, but not apparent or detected. So the first objective in this study was to estimate the accuracy of thoracic ultrasound when compared to calf respiratory scores and HAP blood testing to diagnose active pneumonia in pre-weaned dairy and veal calves using Bayesian latent class models. Secondary objective, they wanted to assess the incremental effect on thoracic ultrasound accuracy of combining thoracic ultrasound with the right cranial part of the lung lobe, which hasn't really been sort of studied before as much, and combining that with results from the right caudal part, because the right cranial part is quite important for dairy calf pneumonia. Tertiary objective was to determine the accuracy of various depths of consolidation thresholds. So over and above 0 centimeters of consolidation, 1 centimeter or 3 centimeters for the diagnosis of active pneumonia. And again, there hasn't been one study which has done multiple cutoffs. Well, there hadn't been at this stage in 2019. So, two hypotheses for this study: that thoracic ultrasound will be an excellent test to detect the active pneumonia, and that combining thoracic ultrasound of the right cranial part with the pre-existingly studied caudal parts will increase the sensitivity of thoracic ultrasound. So just as a reminder, test sensitivity is the proportion of false negatives that you get. So a higher sensitivity means fewer false negatives. So how did they go about it? So in this paper, they've presented data from two different prospective cross-sectional one-gate designs conducted in two different populations. So our first set is our veal calves, numbering 209, all assembled from local auctions onto one farm at 7 days of age, vaccinated, and had the tests applied to them on that day at 7 days old. Our second population, a very different population, is the dairy calves, numbering 301 across 39 herds, 6 to 12 per farm. The median age was 38 days, and the farms were chosen for convenience of access and handleability by the farm vets that were studying these animals. So, for the thoracic ultrasound section, I've highlighted Buczinski in bold because that author was involved in both these studies and was involved across all of these tests, which is good for validity. So across the dairy and veal calves, that examiner was involved, and the examiners were blinded to the respiratory score results. So for both populations, a 7.5 megahertz linear scanner was used, which is pretty standard for an on-farm rectal scanner. Imago for the veal calves and a Buczinski for dairy. 70% isopropyl alcohol was the coupling agent. And the mid to ventral portions of right and left lungs caudal to the heart, which are the caudal sites, and the parenchyma cranial to the heart on the right-hand side, so this is the new site, were included, and the maximal depth of consolidation were recorded for caudal and cranial parts. So this is just to show you the locations on the left and the right side of the calves. So this particular calf looks to have been clipped, and there's no mention of the other calves being clipped for examination at all. So I think this one has been clipped just for demonstration of the areas. And you'll notice on the right-hand side, the right cranial portion is actually below the triceps muscle of the forelimb. So it's quite a tricky area to access. The respiratory scores were performed on the same day as the ultrasound, and a score over 5 meant bovine respiratory disease positive, which we had to assume also means active pneumonia, seeing as this is one of the reference tests. And all the observers were trained by Buczinski, which is good for validity, and they were blinded to the ultrasound results. For the HAP blood test, this was done as the third test of the day after the other two, and a concentration of over 15 grams per deciliter was positive for active pneumonia. So there were several case definitions of thoracic ultrasound studied. So they were very thorough with this particular paper. And the positive definitions, so as in positive on ultrasound, were anything over 0 centimeters consolidation, 1 centimeters and 3 centimeters consolidation as varying cutoffs. And other criteria were the bilateral caudal sites only versus finding a lesion in the right cranial site only versus combining the right cranial and both caudal sites. So 3 different sites to find positive lesions as well. And just a quick discussion about the Bayesian latent class model. So in order to make this class model work, you have to identify your latent variable and make important assumptions. So the latent variable for this particular study is that is the presence of active pneumonia. So it includes 2 statuses. The first one is that we have 1, active pneumonia, which is lung lesions on thoracic ultrasound plus active inflammation as marked by a positive HAP or positive calf respiratory score. The other possible status is non-active pneumonia. So that's going to be lung lesions with no inflammation. So that's going to be a positive TUS, positive thoracic ultrasonography, but negative on CRSC and HAP. Or chronic cases or no lesions. So for no lesions, that means we're negative on thoracic ultrasound. As for chronic cases, there was no explanation as to how that would manifest in testing. So that was a bit unusual as a comment. 2 important assumptions were made on this Bayesian class model. All 3 tests were conditionally independent, so they don't relate to each other, they can't affect each other. The testers were actually very thorough and they did investigate statistically whether there was any correlation between or any interdependence between the 3 tests, and they found a very small amount of interdependence between CRSC, so the respiratory the respiratory score, and thoracic ultrasound, but it was very minor, and they concluded that it didn't actually affect the results at all. But I appreciated how thorough they were in ruling that out. Secondly, the sensitivity and specificity of all 3 tests were the same for both populations, so same sensitivity and specificity for veal calves and dairy calves. So, results. First of all, huge table to look through. So this results table shows you the number of calves with given tests profile results using the 3 tests of thoracic ultrasound, the HAP blood test, and the respiratory score on the veal and dairy calves as a function of thoracic ultrasound case definition. So we've got some take homes from here, which I've highlighted. So the proportion of animals positive to all tests was low, and a large proportion of calves were negative on all. So to the left-hand side, our green box, very low numbers positive to all 3, which is nice to see. And also nice to see on the right-hand side green box, we've got a large number negative on all tests, so pretty healthy population of calves. Yellow box, we've got a greater proportion of animals positive. The proportion of animals positive to thoracic ultrasound was greater than that of the 2 other tests, the respiratory scoring and the HAP blood test. The dairy calves were more likely to score higher across most scenarios, except the scenario where we are positive for all 3. So I've highlighted this in red, although it must be borne in mind that there were approximately 100 more dairy calves than veal calves. But the dairy calves were older, so it's a question of how significant that age difference is for how likely they were to test positive. So the blue marker, the blue boxes here, are just highlighting that these were the calves that tested negative on thoracic ultrasonography, so a normal thoracic ultrasonography test. As such, it is unclear how they can therefore be ranked by thoracic ultrasound threshold on the left-hand side menu. So whether it's 0 centimeters consolidation or 1 or 3, that was unclear. The next results page is estimates of the sensitivity, specificity, positive and negative likelihood ratios of thoracic ultrasonography for the different case definitions in the different populations. So just as a reminder, the different case definitions are the depth of consolidation and the location. So more take homes on this particular table. The first one is that the sensitivity of thoracic ultrasound was relatively similar across the different case definitions, which is nice to see, and it's also quite high. Secondly, in general, when you request a higher minimal consolidation depth, this led to increased specificity, which is great. So fewer false positives with minimal effects on the sensitivity, which is delineated by the orange arrow there. For thoracic ultrasound consolidation depths of 0 centimeters or 1 centimeter plus, adding in the result from the right cranial site increased the sensitivity, but it did decrease the specificity. So we had fewer false negatives and more false positives. What you will notice from the second red box down is that there's some data missing, and that data was not actually included in the paper, which was a bit confusing. Our blue box here shows that if you have a consolidation threshold of at least 3 centimeters, when you then added in the cranial site on the right, it did not affect the specificity and sensitivity estimates. Overall, the scenario which gave us the highest specificity to detect active pneumonia was when the cutoff was considered 3 centimeters consolidation for a positive ultrasonography test, caudal to the heart without using the cranial site. And this is marked in purple. So using this threshold, the sensitivity was 89% and the specificity was 95%, which is pretty decent. Adding in the cranial site, ultrasonography, decreased the likelihood ratio of positivity, regardless of depth of consolidation, and that's highlighted by the yellow boxes. Again, you'll notice there is some missing data. And last of all, from this table, the scenario with the highest positive likelihood ratio in blue, 17.7, was when thoracic ultrasound was considered positive if the consolidation was deeper than 3 centimeters, caudal to the heart only, without assessing the cranial site. So a lot of take-homes from that particular set of data. So, as a reminder, positive predictive value is the probability that subjects with a positive screening test truly have the disease, but negative predictive value is the probability that subjects with a negative screening test truly are healthy and do not have the disease. So, the testers here actually modelled the PPV and NPV for a variety of prevalences of active pneumonia within the possible population. So it's a feasible scenario where you could have a prevalence of anywhere from 2.5% to 20% of pneumonia, and potentially higher if it was a particularly badly affected herd. So encouragingly, as we vary the pneumonia prevalence from 2.5% to 20%, the negative predictive value only decreased from 0.99 to 0.92. And conversely, the positive predictive value increased by a factor of 2.6 over the same disease prevalence. So encouragingly, it does increase. And the conclusion from this is that thoracic ultrasound can absolutely be used as an add-on test to confirm a suspicion of active pneumonia. So, hypothesis 1. They don't actually comment on whether they've accepted or rejected this hypothesis, but the hypothesis was that a thoracic ultrasound will be an excellent test to detect active pneumonia. The sensitivity was 89% and specificity was 95% at its best outcome, its best case scenario, which is pretty good, I would say. So we're going to call that accepted. It's certainly not rejected. But hypothesis 2 was rejected, which is that combining thoracic ultrasound of the right cranial part with the caudal parts of the lung will increase the sensitivity of the test, and that was absolutely not the case. So to discuss, if you evaluate just the caudal sites, left and right combined, using a 3 centimetre depth of consolidation as your threshold for a positive test result, you get the best combined sensitivity and specificity. However, there was a low prevalence of sick animals in this study in both populations. The study therefore lacks the power to estimate sensitivity with accuracy. So it's difficult to know that the increase in specificity with greater depth of consolidation is not achieved actually at the expense of sensitivity. The paper didn't show that, but their comment is we didn't have the number of sick animals to be sure of that result. In a study conducted by Ollivett in 2015, 4 out of 5 of the most severely affected subclinical calves, so this is ones that are severely affected ultrasonographically, would have been classified as completely normal without scanning the right cranial part, because the lesions were actually only visible from the right first and second intercostal spaces. But in this paper, adding thoracic ultrasonography of that right cranial part of the lung did not actually lead to an increase in sensitivity. It actually led to a decrease in specificity, i.e. more false positives, though take care with low disease prevalence as mentioned previously. So the comment is, did the addition of thoracic ultrasound of the right cranial site actually lead to observation of lung consolidation that was not necessarily active, i.e. fibrosis or scarring? And then there's a further comment, could this actually be the case for any animals with mixed lesions? And it's not inconceivable that a good proportion of animals, particularly the older dairy calves, could have older lesions and younger lesions within the same thorax. So that kind of confuses the picture a little bit. So was the thoracic ultrasound and respiratory scoring sensitivity and specificity different for veal calves versus dairy calves? It's a good question. The authors found similar results and 95% confidence intervals for both populations, so they're quite happy that that's not the case. But there was no specific comment on the significance of the difference in the two populations' ages. So the veal calves were all 7 days old, and the dairy calves were a range with a median age of 38 days. So the dairy calves more likely to have fibrosis, scarring, chronic pneumonia, potentially different pathogens, and potentially mixed appearances of their lungs if there was disease going on. And then for limitations of this study, we have a relatively small difference in active pneumonia case prevalence between the populations, between the veal calves and dairy calves. So usually, jointly modelling results from different populations actually would increase the precision of your sensitivity and specificity estimates, because you've got a greater kind of range of biological happenings within your test population. But they didn't have that within this particular study because of the low and similar prevalence in both populations. And there was an absence of information about etiological agents, which I think sort of does imply that the age of the calves has been considered. But different etiological agents will cause different appearances of pneumonia, and that is known. So the comment was that that should be looked at in the future. So that's that. Thank you for listening. I hope you've enjoyed it and learned something. If you've got a question, please get in touch by emailing us at clinical@imv-imaging.com. Otherwise, we look forward to seeing you at our next journal club. So thank you very much and see you again.